assembly line. Each segment has a different function and therefore has distinctly different looking cells. Up here in the capsule, the function of that area called the renal corpuscle is to filter and then channel that filtrate away. So it's got a bunch of capillaries in there, anywhere from 20, some texts say 50 different branches of this afferent arteriole forming this ball of capillaries. And then on top of the capillaries, you have these specialized epithelial cells called podocytes. The podocyte means it has little foot processes, and the foot processes interdigitate with each other. And they're forming part of the filtration barrier that to the fluid that's coming out of the capillaries. What's not shown here is some other cells called mesangial cells. But we have intraglomerular mesangial cells, and we also have some that are out here called extraglomerular mesangial cells. So talk about those later. The filtrate, the fluids, plasma comes in the afferent arteriole, branches into the capillaries of the glomerulus, which are fenestrated. The fenestra, or windows, are small enough to restrict blood cells, so those don't get out. But some, and big proteins can't get out. But some small proteins do, your electrolytes do, your water does, your glucose does, and even some peptides will get out into this glomerular space. The fluid then will go into the proximal convoluted tubule, named because it's located closest to the glomerulus, so that's the proximal part. And convoluted means it's twisted. When you talk about somebody having convoluted ideas, it means it's really hard to follow your ideas because they're going all over the place. They're taking tangents all over the place. So this is a twisted tubule, so proximal convoluted tubule. You look at the cells on the inside. They stain darker pink than any of the other cells, and that's because they have more of the organelles in the cell. They have tall microvilli on their apical surface. What's not shown there is the glycocalyx that's attached to these microvilli. That extends into the lumen and gives it that smudgy pink appearance. So it's not clear here, it's got smudgy pink glycocalyx in it. There's a lot of mitochondria. This is highly metabolically active cells. They're creating mostly a secondary active transport system. Up here, things are passively absorbed, but then you've got to maintain a concentration for that passive absorption. So you need the ATPases for that. Some things have to be actively transported across, and so that will need ATP as well. So a lot of mitochondria there. What is reabsorbed from the proximal convoluted tubule is for every particle that's reabsorbed, water follows. So whatever your osmolarity is when it enters, the plasma enters the Bowman space, it's going to be the same osmolarity when it leaves the proximal convoluted tubule. Because solute and water are going unit for unit out of this fluid. So yes, the osms go down, but water follows. So the osmolarity, if it was 300 entering Bowman space, it's 300 going out of proximal convoluted tubule. 70% of everything that was filtered is brought back into the vascular system by the time you leave the proximal convoluted tubule. Those workers on that assembly line are really busy. When you enter the descending limb, it's a thin limb. It's referred to as the thin descending limb, and it's simple squamous cells. These are permeable to water. but you've got to have a gradient for water to move. The first time any fluid hits that tubule, it has solute in it, but the interstitium does not have solute in it. So there is no gradient for water to move out of the limb. Actually, water wants to go into the limb. But when you get to the other side, you have the thick ascending limb. You see it has more mitochondria. It also has transporters there for sodium, potassium, and chloride. We talked about NKCC transporters last semester, and they're in those cells. So they're transporting sodium, they're transporting potassium, and they're transporting 2 chlorides. So every time the cell transporter moves, you've got 2 chlorides, and you've got potassium, and you also got a sodium going into the cell, and then that will go out of the cell into the interstitium. The first pass of fluid through this thick ascending limb, you start to build your osmotic gradient for the water to leave on this side. When these cells here are so efficient at pumping osmos out that by the time the fluid gets up to the distal convoluted tubule, it's actually less than 300 milliosmoles. So it's more dilute than the filtrate was. It's more dilute than what left the proximal convoluted tubule. And even when you have your interstitial gradient set up, and water's leaving this side and concentrating the filtrate when it goes down to the tip, and as it's ascending, it pretty much doesn't change. By the time it gets to the distal convoluted tubule, it is always below 300 milliosmol. It does not matter what the filtrate enters as. It could enter at 1200. It's still going to be below 300 when it gets to the distal convoluted tubule. That's how many of these transporters you have and how efficient they are in getting that solute out. Distal convoluted tubule doesn't do anything until a hormone tells it to. These are pretty lazy workers. If the boss is around, if a hormone's there, like aldosterone, then they'll go to work. If there is some ADH around, then other parts of that assembly line will start reabsorbing water. Same thing with the collecting duct and the collecting tubule. They don't work until the boss comes around. You gotta have the hormone to tell them to do the work. Otherwise, they are shut down to minimum work effort. Just enough to still get the paycheck, which is their glucose and fluid and other nutrients, but nothing above that level. ADH arrives, then they're busy, really, really busy assembling and inserting aquaporins into their plasma membrane. They'll be reabsorbing a lot of water from the collecting duct, and then that will go into the blood vessels that are paralleling those loops of Henle. The thick ascending limb, we went over that. It looks kind of like the collecting duct and kind of like the distal convoluted tubule. So that's why there's that splitting of hairs. Well, is the macula densa part of the thick ascending limb, or is it part of the distal convoluted tubule? Think of it as its own space. That area where those cells are all crammed together, it's an osmoreceptor and it's also a baroreceptor. It has specialized function there to look at sodium, look at water, and determine or infer from what's passing it what the blood pressure is and what compensatory mechanisms must be put in place to get it back to normal, either raise it or lower it or keep it the same. So macula densa is right around, right around this area. The illustration here is wrong, it's misleading, it is a pain in the butt, it's correct in Sherwood. It's only drawn this way to simplify the picture. This part of the thick extending limb distal convoluted tubule, it's not on this side. It is crossing over and going back between the afferent and efferent arteriole. And then the distal convoluted tubule will go off to join the collecting duct, which may be on this side, it may be on that side, doesn't really matter, just needs to have a hookup. But it is extremely important that the macula densa be close to the afferent arteriole. And it has to be close to the afferent arteriole because the afferent arteriole has cells in its cells lining it that have the renin that will be released to start the angiotensin-aldosterone system. Renin-angiotensin-aldosterone system. If the fluid pressure, sodium concentration over here is insufficient or too much, how do you tell the cells way over there to start releasing renin? It would take a long time and it would take a lot of paracrines to make that communication occur. But if those cells are right next to the afferent arteriole, you don't have to release many paracrines, you don't have to release in high concentration, because there's a very short diffusion space to cross. Collecting tubules and collecting ducts. Collecting tubules, they're kind of cuboidal in shape, kind of squashed in shape, very little in the way of mitochondria. They're not doing much until a hormone comes along and turns them on. They can reabsorb sodium and potassium, but it's regulated absorption and secretion of sodium and potassium. They also handle hydrogen and bicarb, but again, only when the proper hormone is telling them to handle sodium and bicarb. And then down in the papillary duct, this will get a little bit taller in the shape, and it will approach columnar. When you get to this appearance here, you're in what's called a papillary duct, and from that point on, you cannot change the filtrate anymore. So in the collecting tubule and the collecting duct, you can still alter the filtrate. But after the last tubule feeds into the collecting duct, then you can't alter that filtrate anymore, and you have urine that will then go into the minor calyx. So we'll go back to the renal corpuscle and look at it a little magnified. This afferent arteriole, the smooth muscle there, has the renin granules. And that will then, upon paracrines coming from the macula densa to the cells in the afferent arteriole, these juxtaglomerular cells that have the renin granules in them, they're modified smooth muscle cells that have that enzyme in them. When the macula densa sends them chemical messengers to those cells, then renin is released into the blood. The angiotensinogen is always in the blood. When it comes in contact with renin, it's converted to angiotensin 1. And that's the beginning of the angiotensin-aldosterone system. So macula densa controls renin release here. Macula densa also can control the true smooth muscle that either constricts or dilates the afferent arteriole. Again, notice that the afferent is bigger, the lumen is bigger than the efferent. That means less blood is exiting the capillaries than is entering. So there's a fluid pressure building up in the capillaries that will favor filtration. If you constrict these smooth muscle cells, then less blood flows in, more efficient to get it out. That means filtration pressure will decrease. You won't have that pressure difference with the blood coming in versus the blood leaving. If you constrict smooth muscle downstream, then you heighten the pressure in the glomerular capillaries and you increase filtration. So these smooth muscle cells, they're under paracrine control, and these smooth muscles and these smooth muscles are also under your autonomic nervous system, your sympathetic control. This is a picture of your podocytes and their little foot processes that are interdigitating with another podocyte's foot processes. The capillaries are fenestrated under there, and they're going to share a basal lamina with these podocytes. That basal lamina is acellular, as all basal laminas are, but it's got dense connective tissue, not dense enough that it restricts fluid movement, but dense enough that it's going to keep large particles from getting through this filtration barrier. So all these fluids, electrolytes, glucose, small things get through, and then they enter the tubular hole and into the proximal convoluted tubule, which then right away starts reabsorbing the important things like glucose right back, and water following the glucose, amino acids, and other things you can't afford to lose. You'll get them reabsorbed, at least 70% of them reabsorbed right away. The capsular epithelium is just simple squamous cells. That will be your parietal epithelium. It's the visceral that is the specialized cell called the podocyte. The cells in here, this area, these are extraglomerular mesangial cells. They used to think that erythropoietin came from them, but now they know that they're not the source of erythropoietin, but cells in this area that are in the interstitium are the source of erythropoietin. So going kind of back into a gray area, what do these mesangial cells do? There are intraglomerular mesangial cells that we'll talk about shortly. They're not the same as these extraglomerular mesangial cells. So if you look at the rest of this figure, you're going to see that intraglomerular mesangial cells. That's in 26D. So what we're looking at here is 26.8C, and I did forgot the 8, but if you look at the rest of the figure, you're going to see in D, you're going to see fenestrated capillaries, and you're going to see a cell in this area that's nucleated, and it's labeled as an intraglomerular mesangial cell. Inside the glomerulus, as opposed to these which are outside the glomerulus. This guy is contractile, and he's also phagocytic. So his job is keep these filtration areas where fluids want to leak out into through the basement membrane, through the podocyte foot processes, keep them cleaned out. You want some particulate matter to get stuck in there because that creates a sucking force for water to leave the capillary. So this is the lumen of the capillary. You want some things to get stuck in there, but you don't want it to get so full of things that are too big to get through that it stops all filtration. So these guys will phagocytose and keep the barriers clean, and they also contract to pull on the capillary to close these fenestra down a little bit to limit the fluids that get through. So by contracting, they decrease filtration. By phagocytosing, they're helping to keep filtration occurring by cleaning out the filtration barrier. So high magnification. We've got our capsular space. We've got all these dark nuclei, these big nuclei. Those are your podocytes sitting on the capillaries. You can see some little clear areas in here, probably lumen of capillaries. The fluid comes in and then it exits the tubule that has the glycocalyx in it. So proximal convoluted tubule, the smudgy pink, that's your glycocalyx. On the other side, you should have your vascular pole, but you can't always get what you want on a slide, because wherever the section occurs, wherever the capsule is tilted, so the vascular pole may be above this section, it may be below the section, but it's not at the same level that happened to catch the proximal convoluted tubule. But it's on exactly the opposite side. On the opposite side, you see the distal convoluted tubules. They're nice and clear and open cuboidal cells. So this area here looks like the area of the extraglomerular mesangial cells. So out here, there's probably somewhere above and below macula densa and afferent and efferent arteriole. This didn't happen to be on that area of the slide. Okay, so then I've got another picture, and it happened to catch the this glomerulus. It has its macula densa. All the cells are pushed together. It's got cuboidal cells on this side of that tubule, which implies it's either end of a thick or the beginning of a distal convoluted tubule. Got other distal convoluted tubules in that area, so it might be hooked up to that. It might be from another glomerular capsule. Got Bowman space again. Got openings that probably are capillaries, and then your podocytes. We've got proximal convoluted tubule over here, but you've also got cuboidal epithelium that is here. So it's this proximal convoluted tubule isn't hooked up to that glomerular capsule. And here you don't see the proximal convoluted tubule. You've got cells of your epithelium. So the proximal convoluted tubule is somewhere either above or below this particular section. So nephrons will form the filtrate via what comes through this filtration barrier. We'll talk more about that when we get into Sherwood 14. The fluids will get collected into the minor, then move into the major, through that into the pelvis and ureters, and down into the urinary bladder. Urinary bladder, when it's empty, will have temporary folds like the stomach does. So they're called the same thing. They're rugi. So you got temporary folds in the bladder. The ureters, they look like they're entering on the top, but actually they're going down on the back side of the bladder, and they're entering at the base of the bladder. into an area called the urinary trigone, and in the corners of the base of the trigone. This doesn't have the same rugae as the rest of the bladder, and it tends to have these little kind of channels that funnel the fluid towards the urethra. So the urethra, you'll have an internal urethral sphincter. This is male, so you'll have also an external urethral sphincter that's on the other side of the prostate gland. Females don't have the prostate that's in between the internal and external. This actually is the muscle of your pelvic floor acting as an external sphincter, and so that will be the same for the female. The male also will have the vas deferens that is part of the excurrent duct system for the reproductive tract. That will be going over the bladder from anterior to posterior and then coming down to enter the prostate gland. And as it's going towards the prostate, it's going to collect fluids from the seminal vesicles that will happen during ejaculation. So when you're using this system in the male for reproduction, the urinary system shuts down and you have some secretions from glands in this area that will clear out the penile urethra of urine. And then you'll have a lot of very basic substances, so alkaline substances coming from the seminal vesicle, also from the epididymis that will help to deacidify the prostatic urethra. Then the prostate will also secrete into the gland. And together, the sperm and the secretions from the epididymis, secretions from the seminal vesicles in the prostate, and these small little glands here called bulbourethral glands, those will go out as the ejaculate. So in the male, you combine the urinary system and your reproductive system. In the female, these are distinct. You have urinary bladder, and you got remnants of cells that were part of the fetal circulation that are going to form your uterus, and they'll form the duct system that will bring the ovulated egg to the uterus. And if it isn't implanting and forming a baby, it goes out the uterus, through the vagina, and with all the functional cells that were developed to handle implantation, all of that will slough off along the way and also get expelled out the vagina. And that's the menses of the menstrual cycle. Prostatic urethra and membranous urethra in the male is about 18 to 20 centimeters long, but in the female it's around 3 to 5 centimeters. Your book says 3 to 5 centimeters. So much shorter, more likely that bacteria will get into the bladder in the female than through this long urethra of the male. So micturition is the process of expelling urine from the bladder. It's a reflex. The first urge that you need to go happens when about 200 ml of urine is in your bladder. If you're above the 200 ml, your sphincters relax. And if you don't contract the external sphincter, then you void the urine. Same like your bladder. The bladder is like your rectum, except in the rectum you have a smooth muscle sphincter surrounded by a skeletal muscle sphincter. here you've got a smooth muscle sphincter upstream of a skeletal sphincter downstream. So you have a chance to really catch that urine before it gets out through the opening. The external sphincter is under your voluntary control, like the external sphincter for the anus is under your voluntary control. If you allow your bladder to fill between half a liter to 800 mLs, then that pressure can cause your external sphincter to relax as well as the internal sphincter, and you might have urinary incontinence with not being able to override that expulsion. In females who have had babies, the urethra is divided. Actually, the whole output of your sewer system is divided into urethra, vagina, and anus. So the vagina is connective tissue attached to the urethra. You passing 8 pounds, 7 pounds of baby through the vagina, you stretch that attachment to the urethra way out of whack. The more time you vaginally deliver, the weaker your sphincters become in your urethra, the more likely you become incontinent of urine. Age always causes problems. Your nephrons will become less numerous, so you're not able to form as much urine. You're not able to get rid of as much of your waste products, so things build back up into your system. Your filtration rate decreases because you have fewer nephrons filtering. And what you do to determine glomerular filtration rate is take your urinary volume and multiply it by your urinary osmolarity and your plasma osmolarity to determine GFR. But if the volume is going down, then the overall rate has to go down because it's part of the calculation. So if you lose nephrons, glomerular filtration rate goes down. You have reduced sensitivity because probably receptors, either they're less sensitive to the hormones that are arriving, or there's fewer of the receptors to bind the hormone, or the hormone is in lower concentration, or a combination of all of that. So at ADH, you have less response to ADH. The older people tend to be more dehydrated. You have to be very careful to keep them well hydrated. They are putting out larger volumes of urine. Unless they're running into a prostate that's hypertrophy, then they have problems there. But if no prostate problems, the volume is going up because reabsorption is going down. And so they're trying to go to the bathroom more frequently, may or may not get there, may or may not have urinary incontinence. So micturition problems. If you lose the smooth muscle tone in your sphincter, then you're more likely to have accidents, become incontinent. You also get urinary retention because smooth muscle cells are not as efficient at clearing the urine out. And so more urine in the bladder, more likely to get infections in this fluid due to bacteria migrating into it from up the urethra. Okay, so no claims for chapter 14, but we'll start that on